take a minute to give a brief introduction to our speaker. Dr. Tuuli Metsvaht is a distinguished pediatrician and a professor serving as the head of the children's clinic at Tartu University Hospital and also a professor at the University of Tartu. With over 30 years of experience in pediatric intensive care, her research focuses on pharmacology, including PKPD studies and international trials in neonates and children. So Dr. Metsvaht leads the innovative International Project NeoIPC, dedicated to enhancing infection control in neonatal intensive care units. So her contributions to the pediatric medicine have earned her widespread acclaim and admiration. So today she's going to talk about microbiome in NICU, health implications and potential for interventions. So over to you.
Good afternoon, dear colleagues. Thank you for this kind introduction. And I hope it already said that my very primary commitment has been clinical work over many years. So this will be a very much intervention-oriented clinical talk rather than basic science, but I will use here and there the data. And also, thank you for the opportunity that I will take also to review some of our own research from earlier and some of the recent ones. As the introduction said, that my primary research interest stands in neonatal and pediatric pharmacology, developmental pharmacology, so to say. The subject may be of interest, or it may raise questions why this, but there is a lot for us in the microbiome. Well, for us, I mean, people working in neonatal intensive care, a great potential for those small babies to do better than they actually do today. So I've taken the liberty to try to look into the practical side of this part. What I will talk about will be neonatal microbiome, changes in NICU and disease, interventions to modify colonization, risk of disease, what has been done and what to look. Briefly, the gut microbiota has multiple roles, also in the development of a young human. From maturation of the immune system, nutrient utilization and modification, to prevention of pathogen colonization, but also to major developmental outcomes. Even epigenetic inheritance has been suggested. Overall, human microbiome, it becomes more or less stable by 3 years of age. But we are talking about the very first days, weeks, and months of life in the context of neonatal intensive care, which I will use the abbreviation NICU, if that's okay with you. If I'm using some unknown abbreviations without noticing myself, please let me know and just ask, what is it all about? We know that the baby is born with little or colonization. Meconium levels have very low complexity at the phylum level. On the panel A here, you can see the relative abundance of different phyla in meconium, in contrast to on panel B, that of the mother. They have very few unique species shown on the panel C compared to the mother, and even though it increases over the first 3 months, it remains far below that of the mother. Also, what you can see is that the phylum types are very different. In neonates compared to adults, neonatal microbiome dominated at this moment by actinobacteria, which are actually rare in adults. Recent developments in technology, namely metagenomic sequencing and analysis of rare single nucleotide variances, has allowed also to clarify more the inheritance or transmission of strains, namely on the strain level between for the neonates and children. And as it has been found, is that 87%, 87% of vaginally born infants harbor strains of maternal vertical transmission. And you can see it here on the panel A, and this remains very high over the first year of life. Even non-maternal strains tend to be replaced by maternal strains, shown by the similarity of the SNVs to mother, increasing over the first 12 months. Nevertheless, the species composition, as already shown on the previous slide, remains much less complex over the first half a year, and the shift towards higher species complexity comes only with the change in the diet during the second half of the first year of life. Maternal strains are retained also later in life. Here you see comparisons between different time points of children, or actually, children or neonates who were followed up to young adulthood. And by different phyla, you can see that both similarity over different time points of self-characteristic SNVs, as well as those of the mother, remained high in over all time points to young adulthood. Much less so, but still quite some transmitted from twins or siblings, with little or no difference between twins and other types of siblings. And also the father comes in, especially when we are talking about Clostridia, where the inheritance pattern really seems to be slightly different, with less similarity to the mother's microbiome. When the authors summed up all this, you can see the transmission between different family members. You can see that the mother and child keep the exchange over the study period, but also that the father becomes one of the main donors of new incoming strains, which is interesting in itself. And also, of course, siblings have certain exchange quite at high levels. When we now shift all this normal development, close family contact, persistence of normal microbiome into the context of neonatal intensive care, where all the protective factors, close family contact, hopefully healthy diet, avoidance of any harmful interferences, breastfeeding, which are all the cornerstone of the development of a healthy child or healthy newborn. We change all this into the stressful environment of intensive care, with the mother probably staying in hospital for prolonged times, poor diet, lots of stress, maybe decrease in breast milk amounts, requiring formula feeding, or maybe conditions not even allowing enteral feeds and thus parenteral feeding or antibacterial therapy. We definitely end up with a very different situation, both in the gut and also in terms of long-term outcomes for this baby. I'm not talking only about acute diseases like sepsis or necrotizing enterocolitis, but also disturbed immune development and psychomotor development. Maturation of gut microbiome in late preterm versus preterm infants has its own specificities. This applies also to more preterm babies, but this is a nice study recently performed by our Nordic colleagues in Tartu University Hospital, so I chose this one. And as you can see here, the taxonomic composition shown in panel C is really different. Preterm babies are harboring a lot more staphylococci and almost none or very few bifidobacteria. And of course, the diversity is much lower at the early age. This diversity difference disappears, however, only by 6 months of age. Preterm neonates, and these were relatively healthy preterm neonates from 32 to 36 weeks of gestation, who could be enterally fed, because this was the other part of the study. I will show a little bit later. You can see that by 6 months of age, these dissimilarities more or less disappear, but the species composition also becomes more comparable. So the preterm microbiome unique maturation pattern is predicted not only by environmental factors, but also differences in the immature gastrointestinal tract. Underexpression of tight junction proteins, lack of mature goblet cells, and patchy mucus layer all lead to increased permeability, lowered barrier function of the mucosa of the immature intestine. Also, immune system immaturity has its own effects with reduced secretory IgA expression, higher levels of pro-inflammatory compared to cytokine, pro-inflammatory cytokines and calprotectin compared to term babies. All this leads to differences in microbiome associated with also much more neutral pH of the gastrointestinal tract. And on the media panel here, you can see the relative abundance of different phyla. As said already, Staphylococci are the first to come, followed by Enterobacteria and Enterococci, and only near-term bifidobacteria increase their abundance to somewhere nearby that of term babies, but still it remains slightly different until, as I showed, up to about 6 months of age. Why is it all relevant for us in neonatal intensive care? There are profound implications for pathophysiologic concepts and possibly novel therapeutic strategies. As you will see a little bit later, perhaps not yet, but still something has been achieved, and I hope that more is to come. Definitely well established is the risk of necrotizing enterocolitis and sepsis in neonates treated in intensive care. The development of necrotizing enterocolitis, which has been considered over many decades a multifactorial inflammatory disease, where possibly not only immune mechanisms, but definitely the microbiome, you can see here the firmicutes and predominance of proteobacteria are associated with later development of necrotizing enterocolitis, a multifactorial total disease, but no good intervention so far has been able to eliminate the risk completely. And the other acute disease definitely is late onset sepsis. To show some of our own research also, we studied hospitalized preterm neonates in our two neonatal intensive care units in Italian Children's Hospital and Tartu University Hospital, and namely colonization by coagulase negative staphylococci, also characterized by different resistance and virulence factors. Here you see the division by MECA negative or positive coagulase negative staphylococci, and we were able to identify 4 main colonization patterns. On the lower part of the panel, you see that those who became colonized with MECA negative maternal milk strains of coagulase negative staphylococci, staph epidermidis namely, were unlikely to develop sepsis. None of these infants had sepsis later on in the course of disease. In contrast, those who colonized early within the first or second week of life with highly virulent Staphylococcus hemolyticus, MECA positive, were very likely to develop sepsis, so showed here as black squares. And the day of life when they develop sepsis is also shown behind these squares. And the 4th pattern, colonization of MECA positive staph epidermidis, NICU predominant strains, was also associated but with much lower risk of sepsis, only in 2 cases with a larger number of babies. It has colonization with maternal strains was associated also with higher intake of these microorganisms from maternal milk, which was actually a surprise for me, because at those days we were actually limiting the number of coagulase negative staphylococci in breast milk that was allowed to be given to babies, because transfer of, for example, gram-negative pathogens with following late onset sepsis has been described in multiple cases in neonates. However, after the study, we do not screen for negative Staphylococcus anymore, or we don't have any upper limit that would require pasteurization. We believe that really the maternal milk can be protective against pathologic colonization. The gut colonization and invasive infection are closely related, has been shown in more complex techniques like metagenomic sequencing. And later on, and here you see that an increase in the abundance of the later pathogen increases for almost all relevant neonatal intensive care pathogens like Staphylococcus aureus, Streptococcus agalactia, Enterococcus fecalis, Serratia, and Klebsiella and E. coli, which is really something when we think about the potential for the prevention of disease. However, and furthermore, this association was confirmed by the fact that in all cases, in all pathogens, the abundance peaked immediately before the development of invasive infection in these children, and in 67% of cases at the time of bloodstream infection, the BSE causing species was in the most abundant quartile within the metagenome. So, but it's not only acute disease. Next person, enterocolitis is not a common infection. It's also later psychomotor development. Microbiome plays a role in maturation of immune response, metabolic and hormonal homeostasis. Later childhood diseases like atopic eczema, asthma, obesity, celiac disease, and other autoimmune diseases have been associated with changes in the early development of the microbiome. And more recently, the gut-brain axis and association with psychomotor development has got some support from real-life data. So what could we do? Pro and prebiotics are probably one of the most extensively studied strategies. We could also think about the impact of antibacterial therapy and what we have there, and perhaps modification of the entire environment and treatment routines. Probiotics have a vast spectrum of possible interactions, occupation of niches and generation of cross-feeding networks. They are able to change the microbiome composition, although the strains do not remain in the microbiome much beyond the first month of life. They still can change the composition for this first, probably or possibly most vulnerable month. They change the metabolic profile and lower intestinal pH. They have the capacity to competitively exclude pathogens, enhance intestinal maturation, and hence barrier function, also preventing possible translocation, and they reduce the pro-inflammatory immune profile. The most studied in neonates are bifidobacteria, lactobacilli, and combinations. They all have slight differences in their probably spectrum of action and also their physiological role. While bifidobacteria are persistent members of the infant gut microbiome, lactobacilli are only transilient colonizers. Bifidobacteria more so, but actually both have the capability to degrade human milk oligosaccharides and thereby modify the intestinal lumen environment and lower the pro-inflammatory profile towards more anti-inflammatory. Combinations can also increase in abundance of probiotic genera, decrease in potentially pathogenic microbes, and show also higher concentrations of pharmacometabolites. The accelerated microbiome maturation is actually probiotic formulation specific. Both health promoting changes in immune and metabolic parameters have been demonstrated, and successful engrafting into preterm microbiome as well. The strong anti-candida effect also associated with bifidobacteria is very relevant when we are talking about the smallest neonates with birth weight below 1 kilo, where this is still a major problem and has major detrimental long-term consequences. However, the clinical support is there for the prevention of necrotizing enterocolitis, unfortunately, only predominantly in the larger gestational age group receiving this treatment in many NICUs all over the world. Currently, it's about 28 weeks of gestation, but those at the highest risk are those below 28 weeks of gestation. We're talking about 23, 24 weeks, where this effect has not been so convincingly proven. Also, in most studies, an effect on the incidence of late onset sepsis has been there. And some data support a potential for later improved neuro development has been documented for improved head growth by 36 weeks of postmenstrual age and improved weight gain by 2, 4, and 36 weeks. Prebiotics. Probably no need to explain in this auditorium what are they, but just in case. They are generally a group of nutrients that are degraded by microbiome. In the context of neonatal care, we are mostly talking about protein, character, oligosaccharides. They can selectively influence gut microbiota and thereby influence also the metabolism and integrity of the intestine, suppress pathogens through induction of immunomodulatory molecules directly antagonistic against some pathogens, and also their fermentation products, short-chain fatty acids, have a lot of beneficial effects shown here on the picture in the context of adult care. When we compare pro and prebiotics, still, while probiotics have become kind of routine care in many, not to say most, NICUs all over the world, prebiotics have had much less impact. This is the same study I already referred to from our Finnish colleagues, just recently published, which was comparing probiotics, prebiotics, and placebo. And these effects also can be preparation specific, like I said already about prebiotics. So this is just this study. What they found was that by 1 month, they started within 3 days, supplementation with prebiotics, probiotics, or the placebo treatment. And you see here also a full-term reference group who had much higher richness and complexity of the microbiome in the very early age already. And by 1 month, while the preterm probiotic group had a shift towards the term babies with no difference in the profile anymore present, the preterm reference or preterm control, let's say, and preterm prebiotic groups still differ from that of healthy term newborns. Nevertheless, by 6 and 12 months, no difference between any of the groups was there anymore. As I said, for us, the critical period is within this first month. When we look at a large meta-analysis, prebiotics, although much hope was on those interventions, they are much more attractive in the context of the potentially immune-compromised, severely preterm infant with increased gut mucosal permeability, where giving live bacteria always carries the risk of invasive infection by probiotic strains as well. And this has been documented, although very rarely compared to how many neonates are receiving probiotics currently. But nevertheless, prebiotics would be free of this risk whatsoever. Unfortunately, no major effect, either on prevention of necrotizing enterocolitis, all-cause mortality, late onset invasive infection, or psychomotor development has been proven so far. Another factor we might be able to use to modify the development of the gut microbiome is the antibiotic pressure. We are talking about up to 10% of all neonates receiving antibacterial therapy within their first few days of life. Definitely a more selective approach here is needed. However, we still like precise, fast-acting diagnostic measures, but some improvement over the last five years has been. You can see that in our choice of antibiotics can influence the development of microbiome or the out-selection of certain pathogens. Here shown for ampicillin and gentamicin, for example, either of them will out-select Enterobacteriaceae, while a combination of the two is associated with lower abundance of Enterococci. And for vancomycin, for example, or a combination of vancomycin and gentamicin, when used either of them alone, they increase in the abundance of Enterococci and decrease in Enterobacteria can be seen, but the combination is associated with increased abundance of Enterobacteria. Whether or how this can be practical, the knowledge is not there yet. Also, the duration of our antibacterial therapy can affect important issues like development of antimicrobial resistance. Here you see the differences in resistome in children receiving short, which means 5 days antibiotic treatment for pneumonia, compared to the routine course of 10 days. And you can see that for the beta-lactams, the overall prevalence of resistant genes was significantly higher for beta-lactams, but also, and even more importantly, for multi-drug resistance, which is the increase in pandemic in the whole world, and definitely something we do not want to feed with our current practices. Similar effects have been demonstrated for neonates with mothers receiving intrapartum antibiotic therapy, which is also quite a widespread approach, as long as we are not monitoring colonization, for example, with group B streptococci, which is the #1 pathogen for early onset neonatal sepsis. Risk factor-based intrapartum antibiotic prophylaxis is really widespread, and lack of feeding with own mother's milk was associated similarly with much higher prevalence of resistant genes for the majority of antibiotic classes that we have currently in our hands. What we have been trying to do is to look in a more complex way to the whole environment and the whole approach. What is promoting the transfer of NICU strains, resistance genes, personal contact, lack of close proximity of the mother's type of feeding, raw mother's own milk versus donor milk or formula, which the later of the two have been shown recently not to differ much in terms of any other outcomes than necrotizing enterocolitis. So we performed a small study in Estonia's largest maternity hospital, which is East Tallinn Central Hospital, which already had prior to our study quite in place family-centered intensive care measures. The three main cornerstones of this approach are roaming in of family members, limiting thereby involving parents in the baby's care and limiting personal contacts, promoting skin-to-skin contact and early enteral feeding with raw own mother's milk. It has been shown that it may reduce the incidence or severity of sepsis and transmission of multi-drug resistant organisms, but also some controversy exists in terms that moving from one environment, meaning, for example, into totally new units, may bring along the own microbiome of this new surrounding, which in at least one study, for example, has contributed to increased abundance of resistance genes. So it's not a straightforward relationship. Nevertheless, what we tried was to bring even earlier all these interventions, to leave those babies who maybe need for at least a few hours a close observation to ensure safety in terms of respiratory support and hemodynamic performance, to move them still into single family rooms as early as possible. 48 hours was allowed in the study, but we did it in 1 day, mostly for most babies, to start breastfeeding with own mother's milk as early as possible. And you see, it was already started before our intervention within the first 24 hours, which is in general for most units really very early. We were able to change it into 2 hours, and also to promote skin-to-skin contact, increasing the number of hours per day for the first 4 weeks from approximately close to 2 hours to 4 hours. And what we actually saw, we had analysis only for enterobacteria available at the moment, was that the transition of hospital strains shown in red here and defined as the same strain identified in more than one child family unit was almost after a certain lag period. And here you see the ARIMA modeling results predicted and the actual percentage of hospital strains among all isolates. We were almost able to eliminate the transfer after a lag time. You can see here a very clear and large numbered transmission within the first weeks of the study period. So, to sum up, what are the problems? I believe that the complexity of the interactions required to modify really the early development of the microbiome in NICU are not yet well understood. Most interventions are targeting just one step or one factor, and perhaps a more personalized approach is that what is needed. I have borrowed the future needs and directions wording because some of them perhaps were too bold for me to say them out, but still to have point of care techniques to determine the microbial structures on site and thereby recognize real time those babies at risk. And on the other hand, to have then personalized approaches available would probably be something that we would really be looking forward to. How far away we are yet is being optimistic. I think most things come sooner than we expect them to come, but I'm sure no days can be set at this moment. What we also need is the development of new strategies or diagnostic measures to detect bacterial infections, to really limit the use of antibacterial therapy, especially in the context of limiting the spread of resistance, which is becoming a major problem. Fortunately, not so much in Estonia, but definitely in Southern Europe. We are currently participating in the project that is going to look at the effect of skin-to-skin care or promotion of skin-to-skin care for limitation of the transfer of resistance genes within a NICU. So, to sum up, perhaps what we need is more a One Health-like approach that will bring together all the different aspects, a minority of which I could discuss with you today. And thank you for listening.
Thank you very much for the interesting talk. Now we'll raise questions.
I have no question, but I have one suggestion. Maybe young mothers or future mothers have to take their own dirty bed linens to the hospital.
As you could see, the approach of fecal transplantation, for example, or as also mentioned here, vaginal fluid transplantation, because the mother is the source of the normal microbiome in most cases, is something that has been tried in some, let's say, very specific clinical context, like short bowel syndrome with long-term repeated antibacterial causes to avoid bacterial overgrowth. But most of the descriptions you can find in literature are really successful. And the effect of the transfer in the microbiome on later course of disease or development, let's say, has been well proven in germ-free mice. When you take an antibiotic-treated baby's fecal microbiome and transfer it to germ-free mice, then their cause of weight gain is similarly poor for male rats, as it is. There is a sex difference also, or gender difference in between human babies. Boys have much lower weight gain when they have received at least one course of antibiotics, and this effect transfers to germ-free mice. So yeah, these are very promising approaches. Whether it's dirty linen or something else remains to be identified.
So there is a sex difference.
Yeah.
So the boys having the antibiotics grow less than girls who has given this one. Really?
Yeah.
Yeah, it's very nice because I found the same sex difference in calves. It was very surprised to me. It has happened.
And it was also worse for male cows.
Yeah.
Okay.
It's also seen the same way when.
But the intervention in my study was different because what we did, we actually give these calves colostrum supplement rich with IgG and other things. And it turns out, for some reason, that it works better in females than in males. So I just wondering what it can be. Of course, in cows, it's a totally different stuff because male babies are very viable, but male calves are just a waste. Male calves are just a waste in milk production.
Yeah. Okay.
That's the same reason. But I would like the same thing actually. What about G injection babies? What do you do with them? Or do you do anything with them?
Don't do anything at the moment because, but what has been really well shown and was. You can see on this slide those in bold here are cesarean section babies. They have really almost no transfer. They also from the single nucleotide studies, they have almost no transfer of the maternal strains, but they obtain them later in life, as also shown in this childhood to young adulthood study. The exchange of strains within the family unit.
Yeah, so
they get it later.
the cases is with skin-to-skin contact with mother's milk, this kind of stuff.
But it's still the similarity or the strains that come from the mother's gut microbiome.
So
Predominantly.
if you showed us this picture of mothers and babies were, it means babies samples were fecal samples, mothers also fecal.
Yeah.
Oh, mothers also fecal.
Yeah.
Oh,
It's the gut microbiome comparison.
it's very nice because
Yeah.
we also do it in cattle like that.
Which is, I think, fair enough and really.
You say that it's okay, because we were thinking that maybe we also need a vaginal sample, etc., but in the end, we just run the fecal samples.
I think vaginal microbiome is much less relevant for the colonization of the gastrointestinal tract. They can be probably found in very early phases, like shown here, where almost nothing is there. A few may come from these sources. But coming back to the boys and girls subject, I mean, it's in neonatology, human neonatology. It's also a big problem is sex difference between the overall cause of disease. We know that the survival of male babies is much lower. Similarly, that some detrimental effects are much more pronounced in boys. Anything related to feeding, for example, early studies that were comparing breast milk feeding to formula feeding, there was some effect, maybe also in girls, but it was much more pronounced in boys. And why so? There is no, at least I don't know one plausible explanation. The hormonal background is probably something that has been suggested, but not fully.
Generally known that male are weaker,
Yeah.
weaker in that sense. So I was just thinking, when you tell this, as I was thinking, maybe the mechanism in male calves also goes through some part of this, goes to the development of fecal microbiome and how it interacts with the immune system and this is something I would like to try to look at.
Sorry, I excluded the study, but it's also a Finnish study. I think they just published a large birth cohort that was studying their antibiotic treatment and growth data then for a quite prolonged period. Look into this. I'm sorry, I excluded it and I don't have it.
So we have many questions. I was just wondering about this, the reasons to antibiotic treatment of these quite young babies. So, and still, I understand that we use quite sometimes combination of gentamicin and ambicin. What are the reasons? This is respiratory disease mainly?
Actually, this, and I would now say that this habit dates from 1980s, when suddenly they sprayed a group B streptococci. In pregnancy was recognized or became an important problem, and it can cause devastating disease, with the baby falling ill and dying within 24 hours without you being able to do anything. So a large number of studies address different antibiotic prophylaxis strategies, up to the approach that all mothers received 1 dose of penicillin to avoid the disease in the child, or at least to gain some time to recognize it in a timely way. Of course, currently, the frequency of the disease has gone down dramatically, many times. It's 0.2, 0.3 babies per 1,000 born are currently developed early onset GBS, and we are still treating 10%. So it's a little bit a relic, because we are still afraid that the cause may be so fulminant that we start antibiotics at the smallest hint of deviation from normal symptoms. But tools are being developed, Kaiser permanent neonatal sepsis risk score assessment tool, for example, which allows still to go down in the numbers and take a waiting position, especially when it's a vigorous term baby, then you will do nothing. You can wait much longer. Still, those at highest risk are preterms. Early onset sepsis is much more frequent in them. Many of them are born from chorioamnionitis, which we know is already associated with possibly ongoing infection, and they have culture-positive. And there it's E. coli, the predominant pathogen, at least in some countries. And that's why we are using ampicillin and gentamicin, because our ampicillin resistance is also over 60% in community-acquired strains, so we cannot rely on this.
So thing is with calves, we have enterotoxic E. coli inside 5 days, and nothing is helping them anymore. It's just going because you are too late to do something.
Yeah, you
So
recognize.
they are What about biomarkers? I understand it, especially with the very young and newborns. I understand they have tried for this region to detect very early some cytokines, polyclonal cytokines like interleukin-6 or the NF5 as a marker, early marker. I have read at least some articles.
Yeah, IL-6 is currently used also in our neonatal and intensive care units. The problem, to the best of my knowledge with this, is that the peak is relatively short. And if you miss it, then you may draw false conclusions. However, if it's over already, it's probably not an ongoing or spreading disease, hopefully. But yeah, that's what we are using to have, which was a promise for me first time more than 15 years ago, that we will have genome analysis bedside, also identifying gene activation patterns specific to certain pathogens. Because what we would like to know is whether it's gram-positive or gram-negative, to better target our choices to go with one drug instead of combination. But none has emerged so far, so still waiting.
What about acute phase proteins?
If this is really a severe disease, it can be 24 hours late. What we see also, for example, in older children in toxic shock syndrome, we have a brilliant case in these terms. The parents said that something is wrong with his child and took him to the hospital. CRP was below 1. But he had tachycardia, received some infusion, and by the next morning, less than 12 hours later, he was in full toxic shock. And CRP was over 80, I think, but procalcitonin was near 200 and had a severe cause of multiple organ failure, but recovered fully. But still, the decision was made based on CRP, so we say that there can be really prominent causes of disease where by the next morning you will have elevation in CRP. Procalcitonin is much faster in these terms, but still not a definite answer because it's also slightly non-specific and it has been shown to be elevated, for example, in severe cardiogenic shock with impaired tissue perfusion. It's similar pattern, so it's not 100% infection or not.
There is a tissue damage sometime that it stop.
Yeah, to the best of my knowledge, it has been used also, and we do it as a marker of disease severity. If I have a patient with similar clinical signs, and one of them has PCT 180 and the other has 18, I definitely know that this child is going to be a big problem, and the other one probably not so much.
The same thing with cars. So they are more as a measure of disease, not. We usually don't have very good prediction from this.
To the best of my knowledge, PCT has been also used in animal models of multi-organ failure, just to provoke multi-organ failure. So whether it's a symptom or sign or partly a cause of the disease severity is also, I think, debatable.
But the same thing is actually, I think, that you may correct me that colostrum and marasmic probably will include quite a lot of pro-inflammatory cytokines. At least it's in all mammals I have seen that the colostrum includes pro-inflammatory cytokines already. And what we have seen that the more they have these cytokines, it will increase the cause serum cytokines concentration up to 3 weeks. So, so the cytokine thing is very interesting. You show us the cytokine profile, which is changing more towards the anti-inflammatory, some kind of probiotic segment.
Yeah, because they changed.
Yes, I have one question, sir. Where they are measured in the bloodstream, in the serum, or in plasma, or in the gut, because there was calprotectin also which can be measured both.
Guide protectin definitely is measured in fecal samples.
Okay,
I'm not so sure about the cytokines that I measured, at least in some studies. They have been also measured in gut, but I'm not sure about.
I just asked because we have a theory that the cytokines from colostrum have something to do with immune development and microbiome, this kind of stuff.
In neonates, what I did not discuss is lactoferrin, which has been shown to protect also when supplemented against infection, but it has not become a mainstream. It's just one study and has not become a mainstream treatment, perhaps due to our kind of changes in treatment routines, bringing down the risks. So, yeah, we really cannot give a drug against everything without the baby having anything.
I'm so sorry for wasting your time, but I have one question more.
Please go very.
You show us picture where there was a fusobacterium present in red. How do you feel about these fusobacterium things? Because this is very bothering me in case of cows, in young cows, 2 weeks old cows. Was after that, I think. More. This one. Do I understand correctly? It's not red, but there is fusobacterium somewhere.
Yeah. Here
Walking on delivery here.
part of the to the best of my knowledge, and now I really claim my clinical
Okay,
main
Yeah.
interest, but it can be part of the pater-maternal unit colonization, I call it, but it has not been finally decided yet, as I to the best of my knowledge again, whether it's truly a viable microbiome or it's just the parts of microorganisms that are recovered by metagenomic sequencing. So most of this information comes from metagenomic sequencing.
yeah,
At first, it was a big news that the fetal-maternal unit is not sterile, but later on, it has been still debated, to the best of my knowledge. The role here, I really cannot tell, or I have no opinion. Ratko maybe is a better specialist in the field. They are not a clinical problem.
yes.
So I
We feel that it can be a clinical problem because we found the association of fusobacterium 2 weeks cows with our food face proteins rise. But I just wondered what is there, because fusobacterium is very strange. If it's in cows, it actually occupies most of the bacteria. So it's overgrows in cows for some reason. We don't know why.
am really not familiar with this in children or neonates, but it may be my lack of knowledge.
No, probably there are
Double
differences
check.
between child and cows. At least if I look
Yes,
at them, they are
I've
different.
heard some grows over in humans.
Yeah, we see occasional very strange invasive infections, but they are very, very rare with bacteria that nobody has ever heard before. But that this is not a kind of
Yes,
mainstream problem, but single
Single
cases.
cases were
But I can't report them.
Not-
Bacterium also,
not
even
before
in this
new
context.
bacteria grew over and they
Yeah,
remain.
so it's totally different thing. in
Yes.
cow.
Mhm.
Yeah.
Yeah, so, has any of this study focused IVF babies versus normal conceptive babies, right? Because we expose embryos at the very beginning to antibiotics.
That's an excellent question.
I put the same thing in the test, Mr. Random, but we didn't get it, but to find the answer, but I didn't really get it. Yeah, it was there too.
I'm not aware actually of any studies looking specifically to IVF babies, human babies. And I think part of the reason behind is, for example, in the clinical context, these days, we're not allowed to, we're not supposed to know. So this would be slightly useless information if we're not allowed to know how the baby was conceived. We would not be able to modify our treatment responses based on this information. I have not looked also systematically into this field, but yeah, I'm not aware. The delivery mode, cesarean section versus vaginal delivery, is very clearly there for most cases, and it's always an available information, but I'm not aware of specific differences in IVF.
Because now it's been claimed that they have this growth rates and everything now being coming up, to surface like that. There is a lot of issues. So I don't know, partly because now the clinics which were doing 1,000 cycles now doing 3,000 cycles per year. So use of antibiotics is also high in those things. So, but
I think use of antibiotics is also very high in the context of cattle breeding.
Also.
Yeah. Everyone.
And it's very complicated because cows, when they dry off before evacuation, they use antibiotics there. So
If you started with
of course, in some farms, very young animals develop respiratory disease. So they can be 4 days, 5 days, etc. And it's severe. We need to put antibiotics. So, no other way to.
Do you have data on the etiology, respiratory samples?
Yes, now we have, because we have studied.
And
Oh, it's too early. We just
Okay.
looked at the samples. But we will look at all kind of microbiota from the bowel sample. Biome is very important, and fecal microbiota, and try to put these things together. Then we see, maybe we find out, because what we are talking about in animals, in pigs and in cattle, is the fecal lung axis. So this is something they start to research more and more. We will follow this with a couple of samples, but we don't have results yet. We just started the project about that.
in neonates, what we know is really that the respiratory colonization pattern is associated with the development of chronic lung disease in neonates and application of antibiotics. But these are old studies, I would say, where probably the cause of disease was slightly different, and also the babies affected were much bigger than those we are dealing with currently. But yeah, broad spectrum antibiotics were shown also to be kind of alleviate the cause of the disease, for example. But yeah, currently the association is slightly in question, but differences in microbiome can be seen in those ways.
We hope so that we will see this also some links between one microbiota development and the fecal development.
You are in much better position because bulk material for us is always beyond reach, or you need to have really good reason to get this material. The baby we can think of, but most of them aren't these days. They have non-invasive respiratory support. So you may shed light for us also to a certain maybe mechanisms, and also
we have developed
pathogens involved.
Not developed, and we also use not very invasive method. So usually it was done transstructurally beforehand, but now we do it from the nose.
Bronchoscopy.
No, it's not scope, it's blind. We have two tube systems. So we introduce from the nose to the trachea one tube.
Yeah. Do you need a good
And through this tube, we introduce this long thin tube. And then we introduce 40 milliliters of saline and put this back.
Okay.
Okay, and then we get 6 to 10 milliliters of each back, and it seems to work quite nicely. And which is very important, cows tolerate this very well.
Without anesthesia.
No, and they tolerate this quite well, even the young ones. So it's
How do you know since they got
we believe so. Yes, because we look what happens afterwards. And there is no signs of some depression or something.
To insert the tube as deep as possible. So your
As deep as it goes,
yeah.
slightly.
So
The inner.
presumably you block some narrow airway and then
Yeah,
the fall.
it's totally fine. It's totally different, for example, if you look at the horses, because with horses, they do it, this global tube, which blocks the airway, so the tube has this lancet,
Mhm.
which blocks this. And this is more efficient, you can see,
You can really get the alveolar material. It's
you
also
can know, so,
in bronchoscopy, it's the same,
Yes.
that you have to block it really well to
Yes.
get down to
yes,
the
in
alveolar.
horses, it's quite easy to do, but in cows, you cannot do it with cows this way. So everybody calls them palo, but we like to call this tracheobronchial lavage, not the palo lavage, because probably we will not get palo. We will get tracheobronchial.
Look for alveolar macrophages. But it
Yes.
it doesn't microscopy on this then. That's right.
There's no more questions. Thank you, everyone. Thank you, everyone, for coming today, and thank you very much for your time. That was really mind-blowing. And as a token of appreciation, we have a sticker people. I invite Thomas Roth to present it to you.
Oh,
Take a photo, please.
oh. It's my great pleasure to give you this token of appreciation.
Thank you.
Thank you very much.
Thank you for the inspiring discussion and great ideas also for me to take notes.
Oh, I have so much